Good afternoon, everyone. Welcome to our latest episode of Nashville General Hospital's Wellness Wednesday Facebook Live program. Thank you for joining us today. I'm Kathy Poole.
And I'm Kaylin Harris. Our goal of Wellness Wednesday is to introduce you to Nashville General Hospital experts, have them share information vital to your health and wellness, and give the opportunity to ask questions during their presentation. As you all know, October is Breast Cancer Awareness Month. And today we have a special guest here to discuss Breast Health 101. Our guest is Dr. Frezza, who is a director of general surgery at Nashville General Hospital, and he sees patients in both our Nashville Healthcare Center's General Surgery Center and the Breast Health Center.
Dr. Frezza is board certified by the American Board of Surgeons. He attended medical school at the University of Padua, Italy, and was a resident at the University of Padova, Italy, and Howard University. He completed his fellowship at the University of Pittsburgh and St. Mark's Hospital in the UK. And if that wasn't enough education, Dr. Frezza also obtained his Master's of Business Administration from Texas Tech Rawls School of Business. Everyone, please welcome Dr. Frezza.
Oh, can you hear me? Yep.
Yes, we can hear you.
Well, good morning and good afternoon, everybody. I'm here to see if I can have some question, of course. I'm going to give a quick presentation about issue on the breast. Hopefully are clear enough, and there is anything clear I try to explain on the slides, and see if we can raise some awareness about what we do here at Nashville General for breast health. Back to you guys, or you want me to start presenting? Is any what you want me to do?
Yes, you can start your presentation.
Okay, all right. All right, let me see if I can share the screen and pull up some of those. Okay. All right, you guys seeing well? Everything good? Okay, let's start it then. We have to put this somewhere here, maybe on the opposite side. I'm trying to set up. Okay, as you know, I've been already introduced. We talk about breast health. We have actually a comprehensive breast health here in Nashville General. There is the breast health clinic, which is attached to radiology, where we can do the mammogram and the ultrasound. Therefore, it is one-stop shop, as we would like to say, because the patient comes here. We can review if they have a mammogram and ultrasound from an outside hospital, and then we can provide the care that they need directly here and obtain the mammogram and the ultrasound as the patient are here in the clinic. This has been very important, very proud. In the last year, we were able to double our number of mammogram and ultrasound and number of patients. Seems like more patients are trusting us, and we have patients from everywhere and from every race, and in Nashville, also outside the county. So that's positive, and we're becoming a place for a lot of women to come and ask for help. So what is important to know that every woman needs a digital mammogram at 40 years of age. Now, it seems like that according to the Cancer Society, we might cut it down at 35. But what is really the goal here? Usually we do at 40, we do at 35 as well. And if the patient is less than 30, we start with the ultrasound. So in the breast clinic, we do an ultrasound. Is used as a secondary tools for patients that can obtain a mammogram, but as a primary tool on patients that are 30 and less. And believe it or not, we have a lot of patients less than 30 years old, which unfortunately they've been diagnosed with breast cancer in a very young age. And luckily we diagnose this quickly and early, and therefore they obtain the surgery, and they are currently undergoing chemo, radiotherapy, or what is needed to be by the oncology. And of course, we have the oncology program attached to the breast cancer to offer a comprehensive treatment. So I would like to talk about a few issues about breast. There's a lot of question usually comes, is there a connection between weight and breast cancer? The direct answer is yes. It seems like that weight increase the chance to having breast cancer. Now, in a late term, I can explain to you that the the fat cells produce estrogens. And therefore, with the estrogen is increased risk to have breast cancer, uterine cancer, and other things like that. And of course, with an increase of estrogens, there also a decrease of chance to get pregnant. That's why a lot of women, when they lose a little bit of weight, they get pregnant because they decrease the number of estrogen produced in their fat cells. The mortality, unfortunately, is directly affected negative by the obesity. And the risk increase with the BMI, body mass index. Losing weight does not improve mortality. So if you're already overweight, losing is not improve the mortality. You are what you are when you get diagnosed with breast cancer. And as I say, this is probably an exposure to endogenous estrogen produced by the fat cells. We see a lot of patients in the clinic with breast pain. Now, there are a good thing and bad thing about breast pain. The good thing is, unfortunately, cancer is not painful. It's not painful in the breast, it's not painful in the colon, it's not painful in the stomach, only when it's advanced. So if you have breast pain, most probably you don't have anything bad, but you still need to be checked because there is still 25% chance that can be connected to a cancerogenic. And when I say cancer, I'm talking about malignancy. So I'm talking about something serious. So usually a lot of patient comes to see the surgeon. I'm a surgeon as a training, and you say why the surgeon is running the breast clinic? Because, you know, I like to say that the surgeon starts and ends. We start, mean like we see the patient, we make a diagnosis, we send the patient to whatever is necessary, oncology, radiology, other physician. But if you have to intervene, means surgery, we are there for that. So we start and finish the job. That's why most of the time a surgeon is quote unquote in charge of a breast health clinic. So the breast pain is one of the things that we see a lot. Patients come in for breast pain. Usually it can be one side or both sides associated with chest pain. This is different from the chest pain or the back pain associated with large breast, because a large breast is heavy and give you like back pain. So usually is more common when you have menstrual period associated with when you are ovulating and associated therefore with an increase of estrogen. And it's also associated with the use of coffee. One thing that we told all the patients with breast pain is to avoid coffee. Every coffee and caffeine, from coffee, from Coke, from tea, everything that is coffee increase the breast pain. There is a lot of hormonal, herbal, dietary remedies. Somebody try bromocriptine, danazole, but the best things is an anti-estrogen like tamoxifen, which is used also during on the breast cancer. Low-fat diet is also recommended on patients that have breast pain. So this is like little things that we do, diet, diversification with coffee. And if that doesn't work, you usually send it to a gynecology to try to start them on pills like hormonal control, or the oncology to start the tamoxifen. So what to do when you have a patient that comes with any problems, like, you know, they come for having evaluation, maybe pain, no pain. First of all is a physical examination, which we do here. Second, depends on the age, as I say at the beginning, a mammogram or ultrasound as is indicated. And if there is any problems in it, we try to do a biopsy. And sometimes the biopsy just to show, for instance, the scar tissue. Sometimes the scar tissue look like bad in X-ray, but it's just scar tissue. Remember that breast changes size every time there is a menstrual period. And in a woman, therefore, there is 20, 30 years, time 12 months of changing on the breast. So it can be a dilatation of the duct, it can be a scar tissue inside, it can be a cyst secondary to when they're lactating. There is a lot of possible issues that are not bad, are just that create pain and create an issue that stays. So if there is an issue that we think that we need to have more tests, we also order a core needle biopsy by ultrasound or a mammogram biopsy for this calcification. So So the first things that we find usually is benign is cyst. It usually is more common in women between 35 and 50, but is now I find in also 20 years old. They are non-palpable most of the time, and sometimes are palpable in 25% of the time. Ultrasound is very helpful and diagnostic. And of course, if we have a patient that requires a mammogram, we do a mammogram. We do fine needle aspiration, so we can have some fluid out to make sure that we sample, make sure there is nothing inside. The best things is to have like a simple cyst, but sometimes they're complex cysts. And I see a complex cyst as a house. When you have a house, you have different doors to go to master bedroom, second bedroom, third bedroom, bathroom, kitchen. Think about having a house with different door, and each room is a cyst. That's how I explained the complex cyst. So there is a cyst divided in different cysts, and they have door in between. So sometimes it's difficult to aspirate it all. But usually for cysts, we don't do surgery unless the cyst increase of the size, get bleeding, or turn into any malignancy. And that's why we do needle aspiration, biopsy, etc. What is most common is that in a woman, even at 20, is a fibroadenoma. Fibroadenoma is a benign breast tumor that presents as usually mobile, palpable mass, and most of the time, it requires a biopsy. Why? First of all, because we want to know absolutely that it's fibroadenoma, because it feels like cancer, but it's not a cancer. But unfortunately, there are a few things of fibroadenoma. One, can grow rapidly. Two, can bleed. Three, can actually, in the long term, becomes a real cancer. But usually the fibroadenoma at the beginning is not a cancer. We usually follow the patient every 3 to 6 months, depends on the patient, with an ultrasound to check the size, to check the bleeding, etc. Sometimes when we do biopsy, we find what we call ductal atypical hyperplasia. And these are a precancerogenic disease. Usually there is a mass, we do a biopsy, it comes back an atypical ductal hyperplasia. And most of the time on this patient, we try to excise the area with the atypical hyperplasia, so I mean remove it, because this can be turned into cancer in the long term. Now, other question that comes usually is race and breast cancer has anything to do? I mean, one time they think that there was a problem because usually some people that came like immigrants or something in this country, they didn't have access to the breast centers, therefore they have more breast cancer. But the bottom line, race does not increase the risk of developing breast cancer. Sometimes it can be that you don't have a doctor available because of your location, insurance issue, but does not increase the risk of having breast cancer. Another thing is common, particularly in women post-lactating, during the lactation, and in general, is what we call F.A.C.S and mastitis. Mastitis basically is an inflammation of the breast. Sometimes it comes with nipple discharge, sometimes it's done with redness around the breast. And this is in general due to enlargement of the duct that produce milk. And therefore, bacteria love milk, as kids love milk, as everybody loves milk. It's a good things to eat. And therefore they attack it and they create an infection. An infection sometimes can be superficial, easy to cure mastitis, or it can become an abscess. The treatment for the mastitis is in general warm pad and antibiotic. If it gets worse or if it gets into an abscess, then you require a drainage with a surgical incision. It can be done in a clinic or it can be done in surgery, in the operative room. Gynecomastia is a problem mostly for male, because even male can have problem with the breast. Male can have a problem with cancer, actually. The carcinoma in male for the breast is very aggressive and sometimes lethal. But most of the time, the issue with men is enlargement of the breast. Maybe because they take hormones. In fact, a lot of time I see gynecomastia on patients that actually go to the gym and they take hormone to steroids. And sometimes it's just puberty and on infancy because of the development. And so there is an imbalance between estrogen and testosterone, or because sometimes there is assumption of different drugs can actually impact the formation of testosterone. So all of this is a direct correlation between the production of testosterone and therefore the balance with estrogen, because also men has estrogen in a low quantity, of course, but they have estrogen. About 5 to 10% of the women come to the clinic because they have discharge. The discharge can be from the nipple, can be green, can be white, or can be bloody. So let's talk about the color. Usually it's milky, so because some of the ducts still produce milk, or green because of the fact that the milk stays in the duct for too long. Is usually due to pregnancy, breastfeeding, medication, benign hyperplasia, sometimes to drug. Sometimes can be just yellow. I mean, that can be like a cyst with a serous type of fluid that comes out. And sometimes can be bloody and usually secondary to papilloma, benign ductal hyperplasia. But when it's bloody, it also can be a cancer until proved otherwise. Mammogram, ultrasound, breast MRI, galactography is suggested to make a diagnosis and see what can be done conservatively before passing to surgery. Of course, surgery is always indicated if it is a cancer like papilloma or a real breast cancer. So what type of surgery we can offer? Before, a long time ago, every patient got to do just a mastectomy. So you remove all the breast and the node. And we talk about why the node. But many years ago, we started seeing that there was no difference in survival and recurrence of the cancer when we take a part of the breast. So how we call taking a part of the breast, we call it taking a lump of the breast. So if you divide the breast in 4 quadrants, we have a superior medial, superior external, inferior medial, inferior external. Medial means towards the sternum, lateral or external mean towards the axilla. So you have 4 quadrants. Each quadrant is a lump, and we can do a lumpectomy of each one. You can do a lumpectomy of 1 quadrant or 2 quadrants. And this allow the breast conservative surgery, means that the woman left with some breast, which is very important. What we do though, we do also now a sentinel node biopsy. So we inject some contrast in radiology and some contrast in surgery, and we look to find just 1 lymph node to take out and make sure that that has no cancer. Before we're doing the full axillary dissection, but there was so many complications secondary to arm swelling that we stopped. Only if the node is positive, sometimes we go for a full axillary dissection, but even in that case, not all the time. And the survival is pretty good, 92 to 91% at 5 years, which is comparable to the mastectomy. So lumpectomy and axillary node dissection is a very good surgery for most of the women, but there are like a pro and cons that you need to discuss with your physician, like how you're going to follow, because after the lumpectomy, you always have to have some type of treatment, either chemotherapy or radiotherapy or combination. While instead, sometimes with a mastectomy, you don't have to do that. And, sometimes radiotherapy can be quite involving. The next thing is important, the anatomy of the patient. So what the breast look like, if I take a lump out of the breast, how is the breast look like afterwards? A part can be taken out. So this is all the discussion that you have to have with the physician at the time of the evaluation. When the cancer is not treated sometimes, or where the cancer stays forever, can actually grow and get to the skin. When they get to the skin, give you like an impression that the skin is inflamed, like you have an infection. But a good physician in a clinic can actually diagnose as an inflammatory breast cancer. It means that there's a breast cancer that got into the skin. And then one point, this was kind of deadly diagnosis, but now with chemotherapy, surgery, and radiotherapy after, we have a 5 and 10 year survival rate that is close to 55 and 37% respectively, which of course is very bad compared to the other cancer, but compared to 0, which was like 20 years ago, is amazing. So remember that in this case, surgery is not the first step in treatment, but chemotherapy and sometimes radiotherapy is. One is another question that a lot of people ask or say, okay, I have breast cancer and maybe my mother has breast cancer. Should I have both breasts removed? But the truth is, women with a family history of breast cancer genetic mutation, which we call BRCA1 or BRCA1 or BRCA2, the incidence of contralateral breast cancer can be as high as 47%. So one out of two, so it's not bad. Prophylactic mastectomy was indicated a long time ago, but we showed that there was no survival benefit. And there is no survival benefit in the 10 to 15 years. Therefore, the new analysis, because of no survival benefit, show that this is not necessary to have a prophylactic mastectomy. Actually, the best treatment is taking tamoxifen that actually increase the survival. In general, even the more aggressive the BRCA1 mutation, the life risk of breast cancer on the other side is only 1.2%. So it's not that bad. So prophylactic mastectomy is not something that we do very often nowadays. Another question is like when to do mastoplasty. Mastoplasty means reduction of your breast. There are women that are really in pain. Women have back pain. Women have chest pain because the heaviness of the breast can actually affect all the muscle around the chest and around the back. The recommendation usually is done only for patient with a BMI greater than 30. Age younger than 18 should be not indicated. And usually after a mammoplasty or a reduction of the breast, there is a total reduction of back pain and pain in general. So actually the operation works, but with the right indication, of course. So I didn't talk much about the cancer because, of course, when you have cancer, you have cancer. There's a lot of protocol. There is the lumpectomy or the mastectomy. And then, of course, according to the cancer, the decision-making means what type of oncology treatment, what type of other treatment the patient needs. So, and with this, I hope I cover few of the issues that people will ask, and I'll take a question if there are any questions.
Thank you so much, Dr. Frezza. That was some really important information you provided. Can you share with us the difference between a clinical breast exam and a screening mammogram?
Oh, and Dr. Frezza, you can also stop sharing your screen.
Okay.
Thank you.
Sure. No more sharing. All right.
Thank you.
So I was sharing actually because the number of the clinic was there in case somebody wants to get the number, but I'm sure that you're going to remind the people. So the question is, what's the difference between a breast examination and a mammogram? The mammogram, you go to radiology, you put like under a X-ray machine and you get a shot, a picture. A physical examination, you see a physician that actually touch your breast, quote unquote, and feel it and see it. Because sometimes there is change on the skin that the mammogram don't see. Sometimes maybe I want to do a test, but then I change after I see the patient. So a physical examination is still a very important part of the breast examination and the breast health.
So typically the clinical breast exam comes after a screening mammogram.
Oh,
Or
depends.
not necessarily.
If I see the patient and they have no mammogram, the first thing is always physical examination in medicine. X-ray is always after. But of course, we have patients that come with a mammogram done because the primary physician ordered, or they come from another hospital and they already have mammogram, but I still do the physical examination to complete the workup on the patient.
Thank you.
And then I do have a question. So can a woman receive a mammogram, or can she receive a mammogram procedure that doesn't compress her breast, or do we have the equipment to be able to do that here?
No, I mean, most of the time there's always some compression, because only with compression you can achieve a full vision of the breast. And then, of course, joking or not, depends also of the anatomy of the woman. You know, there are women with a certain size and one with a different size. So sometimes it's very difficult to see it. Therefore, you have to compress. So yes, mammogram, it can be quite painful in certain women. We can do ultrasound in a woman that have pain, and then, you know, screening initially with that. And then if the mammogram is necessary, then go into the mammogram to avoid the pain initially, right?
And then can you remind us, so when is it, when would you suggest for a woman to have her first mammogram? Like, is there a certain age range, or would you say, and I know every demographic is different. So, you know, you have two 25-year-old women, would you say if, you know, one woman has a history, you know, of breast cancer in her family, and the other 25-year-old, maybe she's just not as, you know,
Right.
active, I guess?
So, I mean, on the first slide, I say every woman 40 and above, absolutely yearly mammogram recognized from the American Cancer Society, from the Breast Society, from everybody in the United States. The woman now, they're actually trying to cut down on 35 and 40 because it seems like they want to catch early, because the most important thing for breast is prevention. That's why they're breast health. We see women, despite if they have history or no history, because the best thing for breast cancer is preventing to have breast cancer, or catching up the cancer when it is initial, because when the breast cancer is advanced, it's very difficult. So at 35 to 40, now we start doing mammogram on all of them, because, you know, particularly if they come in a breast clinic. At 20 to 35, so make it a big range. If they have genetic issue, the BRCA1 as we talk, if you have history, the mother, the sister, then we produce a mammogram. But usually we start an ultrasound, and then if the ultrasound is indicative of some problem, then we step into the mammogram.
Okay, perfect. And then we do have a question through Facebook. So does it mean anything if a patient has historically been told she has dense breasts? And then as a follow-up, do dense breasts impede the screening process?
So dense breast is one of the most difficult problem, because when it's dense, you cannot see very well scar tissues versus tumor. So one person that's breast dense is those person needs to have a mammogram every year, needs to have a physical examination every 6 months, and let the physician decide if at 6 months they need also something else. That's why we need to see the patient, and we continue to see the patient, because in certain categories more difficult to make a diagnosis, and therefore we keep seeing it to be sure that we don't, you know, we keep on top of a potential change in the patient status.
And then you talked about, I thought it was very interesting. You talked about caffeine increases breast pain. Like when you said that, I was like, oh my God. I'm sure a lot of the other women that are watching as well were kind of like, oh, I need to put down my morning coffee. But are there any other things that you've seen in your patients that, like those chronic things that, you know, okay, if they take this out of their diet, or if they take this out of their morning routine,
Right.
it minimizes their breast pain?
But usually when the patient comes from, usually women drink coffee. Not all the woman has breast pain drinking coffee, right? That make it clear. But the woman that come in a clinic that have pain, all of the women that have pain that come in the clinic, they drink coffee. So coffee doesn't mean that you're going to develop breast pain, but when you have breast pain, there is a direct correlation with coffee, right? So the suggestion is to cut down on coffee, because if you have breast pain, you don't want to drink coffee to get it worse. But if you don't have breast pain, enjoy your coffee until you can. There are other medications that can produce pain. And of course, it's dependent on woman. I don't go through the list because you'll be creating confusion. The other thing is the breast pain can also is directly correlated with the period, because every time woman has a period, there is an engorgement of the breast, and that the tension, which is usually most of the water, the retainment of the water, something, the tension create breast pain. And then, you know, and everybody then is different, but these are the two things that we know that are connected to it.
Thank you. I'm trying
So
to.
in that same vein, you were talking mainly about caffeine and breast pain, but you had also been talking about prevention. So is there foods you need to stay away from or more foods that you should eat to help with breast cancer prevention?
But in general, there is no a food connected to cancer in general, but there are a few things that we can do. One, antioxidant is important for any cancer or any disease, right? Antioxidant, we're talking about natural antioxidant like green tea, for instance, apple vinegar, turmeric, things like that, that I take some of them myself because it means nothing but increase your immune response and keeping your body without the acidity that helps also in the process and eliminate things that can affect you. Infection, inflammation, cancer. There is though, in general, the only thing that's been showing has been showing that fat food and obesity has direct correlation with cancer. I actually myself published one of the important paper on gut, which is a journal in England, about the correlation between obesity and colon cancer. I did not publish anything on the breast, but there is many papers showing that fatty food, excessive fatty food, and and obesity and breast cancer are connected. So avoid fatty food, uh, stay in shape, which is good for everything, right? So, but there's not really a food particularly to it.
Okay, and then last question. So let's say I'm going to do a hypothetical. You have a patient who has just come in, and she has this diagnosis. Like, what would be those steps? Because right now, a lot of people are talking about, a lot of times when you hear about people having breast, cancer diagnosis, I can only imagine where a woman's mind will go to. But I guess from your advice, from even a mental standpoint, tying that in, what would you say to your patient as soon as they receive this diagnosis?
First of all, when you have the diagnosis, first of all, you have to understand how the patient is. There are some patients that are very strong and they don't, and some patients that are very emotional. So when you see, understand your patient, you might go with somebody, or if you need to talk to them, you always ask them to come with somebody from the family, not to be by themselves. But that's what actually hurt me when I have to talk to a woman that's by herself. Partner is not there, children are not there. It's very difficult. And then you approach it to tell them, I try to tell her exactly like it thinks it is, because it's very difficult to beat the bush when you have a cancer. What you're going to tell? Oh, you have a cancer, but probably you don't have a cancer, unfortunately. And then you confuse the patient. So you have to get to the point, and then right away you tell them what can you do for them, like what type of surgery, what type of chemotherapy, what type of oncology. I think that when the patient has cancer, going around and try to sugarcoat it sometimes can be worse, because some people we might be confused, because there's always the hope that the physician says something that is not true, or make mistakes. So respectful, dignity of the patient that you talk, and be there for them if they need to cry and something like that. I always have extra Kleenex in the so you never know. But some women, they take it well, and they probably because they don't realize it right away, and they realize it at home. So I will suggest all the women that go and talk to the physician about the breast health, always to have somebody with them. The sharing, actually have a patient to vent, having a support system is the most important things for these issues.
Well, that was beautiful, Dr. Frezza. And I think that that's a great way to end our segment today. So, first and foremost, that is all the time that we have. But thank you, Dr. Frezza, for coming on this segment
Welcome.
of Wellness Wednesday. This was very informative, and we really appreciate everything that we learned. And for anyone that's watching, if you have any additional questions, you can still comment even after the live session is over. Or if you need to schedule a screening mammogram, please call 615 341-4543.
Can I
Again,
can I say something?
yeah,
Actually, the same number, you can actually schedule a visit because that's important. Because sometimes you want to schedule a visit and then we schedule the mammogram.
we'll see. Thanks. He doubles in on the marketing team as well. He has that's something we forgotten about. He has a background marketing. So please call that number if you want to schedule an appointment or a mammogram, and it's 615-341-4543. And you can also visit our website at nashvillegeneral.org.
All right.
Yeah.
Very good then.
Thank you so
Thank you very
much,
much.
everyone.
Have a great
Thank you.
day.
You too. Bye-bye.
Bye.